So I'd like to welcome to this 13th session, Peds Picks for Practice, Evaluating Sick Children, How POCUS Can Help. We have Dr. Beth D'Amico here with us today. She's Assistant Professor in the Department of Pediatrics at Duke University. We have Dr. Erica Pietam-Nogson, also an Assistant Professor at Department of Emergency Medicine.
I'm Beth. I'm one of the pediatric folks here, and Erica is one of the adult emergency medicine folks. We both do ultrasound. We have no disclosures about this talk. We are going to review very quickly abdominal exams that are relevant in pediatrics. So we'll talk about the EFAST and then how we use bowel ultrasound. And we have a few cases at the end if we have time. So just a reminder for folks maybe that aren't as familiar, what is point of care ultrasound? It is a study that we do as the clinician at the patient's bedside to get immediate information about that patient so that it can help us with management. It helps our procedures with guidance and safety, and it's a pretty limited exam. It's not a comprehensive imaging study. We always remind our trainees to stay in our lane, in that we're not imaging specialists, we're not radiologists or cardiologists, and these aren't substitutes for diagnostic imaging, complete diagnostic imaging, but it does really help us to answer specific questions in particularly emergency settings. So we won't talk much about machine basics, but I do understand that this might be one of the machines that y'all are using. And we can forward some information. There's a pretty good user manual and a tutorial. I was a little intimidated when I looked at this because it's more complex than the machines that we have. So kudos to y'all for using that. I was just trying to even locate my basic buttons on your machine, and I was able to identify there's probably only three or four that I would need, in one being the power button, the other being the 2D imaging mode, which is what we are typically using, and that knob also turns up your gain, so it makes your image brighter. The depth is below that, and then the probe selection is across here. So there are a lot of controls on here that probably go beyond what we need for POCUS. In terms of transducers, most machines, and I saw that y'all have these transducers, which is great. We in pediatrics often use linear probe. It's a really high frequency, so very good at imaging things that are superficial with good detail. So that's a lot of pediatrics. They're not very big people. And this phased array or cardiac or square probe, whatever you like to call it, we also use often for pediatrics, including the abdomen. Just as a reminder, when we are showing images, we work in emergency medicine. So our probe marker will always be facing either the left side of the patient or our patient's head. And when we are scanning, our indicator, it will be on the left side of our screen. And this is just me. Sometimes I pick up the probe and I want to make sure that I'm scanning in the correct orientation. You can always tap the side of your probe and make sure that the probe marker, the area that's marking that, is corresponding to the marker on your screen. So just a little check before you start. And then last two sort of comments, making sure that your images are good quality. So one thing you can do is always adjust your gain. That's your brightness. You don't want it to be too dark, but you also don't want it to be too bright. There's some perfect middle ground there that you can usually achieve. And then making sure that your depth is appropriate for the image that you're taking. So you want your image to be filling up a lot of your screen. You don't want it crunched in the top or running out the bottom. And just as a reminder, there's a ruler on the side and you can change the depth pretty easily. So those are two pretty basic things that you can use to optimize your images. And now we'll roll right into talking about the abdomen. So we'll review just the EFAST and we'll talk some bowel applications as well. So in terms of EFAST for pediatric patients, it is a little bit different than adult patients. We have the same basic questions. Is there free fluid in the abdomen? Is there a pericardial effusion? Is the cardiac function normal? Is there a pneumothorax or a pleural effusion / hemothorax? In kids, the exam is not quite as sensitive, perhaps, as in adults. And so what we talk about is it has a good specificity. So if you find a positive finding on your ultrasound on your FAST exam, there's probably something wrong. Like it's probably true. However, if your exam is negative, it's maybe not as helpful. You might be missing some pathology because children don't have injuries that often have as much free fluid. And so you might not see even when an injury is present. So we kind of caution our trainees, if you see something, great. If you don't see something, it doesn't mean it's not there. You may need to repeat your exam at a later time or use other imaging modalities if available. In children, the most common area to find free fluid is in the suprapubic region. So, just as a quick review, when you're scanning the right upper quadrant, you're seeing the liver, the kidney, the diaphragm. These are just some sort of marked up slides about what is where. And there is a very short video. We'll see if it'll play. For the right upper quadrant view, the probe marker is facing the patient's head. I'm scanning on the right side of the body in the mid-axillary line. I start low near the rib cage and slide toward the patient's head until I see the liver and the diaphragm. From there, I make small movements, like my probe is a flashlight, shining anterior and posterior until I locate the kidney as well.
Thank you. Thank you for the opportunity to present this case to this group. We're really quite grateful for the opportunity. My name is Kearsley Stewart. I'm faculty across the street from you guys in the Duke Global Health Institute on Trent Drive. And with me is um, the Uganda Sickle Cell Clinic team. And I'll introduce them really quickly. Musau Joel Kibonyo-Abake is the director of the clinic. Musau Semanda Benin Bryan is, Herbert Bryan is the focal lab director for the lab at the Kalangala Health Center Level 4. We also have Chakua Benin Bryan, who's a clinician in the sickle cell clinic. I believe we have Julius Mushangi with us, who is a Master's of Science student in the Global Health Program and who is writing his master's thesis based on his clinical work this past summer at the Kalangala Health Center. Forgive me if I missed anybody else. I think we have Zechariah, who is a young volunteer trainee at the clinic as well. So we're going to talk for about 5 minutes. I'm going to start with the introduction, and then I'm going to hand over to Musau Joel Kibonyo-Abake, who is the clinician, to present the case. So I have been working with Joel and his team at the Kalangala Health Center for about 5 years since COVID, collaborating on at their sickle cell clinic. Their sickle cell clinic was founded in 2013 or 15 by Joel himself with 2 patients. It's now grown to 120 patients. It's a weekly sickle cell clinic every Tuesdays. It's located on a remote island. If you know the geography of East Africa, Lake Victoria is surrounded by Kenya, Uganda, Rwanda, Burundi, and Kenya. We're in the middle of the lake, which belongs to Uganda. And this is a government facility. It's a level 4 facility, which is one level below a hospital, but for all intents and purposes, it has all the services of a hospital. Of those 120 patients, 60/40 female male. And for this group, I don't know how you define pediatric, but we have 30% of our 120 patients are below 5, a quarter are between 6 and 10, a third are in the teenage years, and only 10% are over 18. And in the collaboration between Duke Global Health Institute and the Kalangala Health Center 4, we send trainees, including Julius Mushangi, who is doing his master's work there. We've sent Duke medical students. We've sent Duke School of Nursing students and undergrads. And through that collaboration over 5 years, we are in a wonderful position to be able to provide hydroxyurea to 80% of our patients, and that's from donor support. Very briefly, and then I'll hand over to Musao Joel for the next page, which is the patient presentation. These data are from 2024. We've been working really hard to build up an electronic database. Nobody else in Uganda has this for sickle cell patients. In 2024, we had no deaths. We saw 82 unique individual patients in 2024. Of those 82 patients, 5 presented with vaso-occlusive crisis, and 50% presented with other symptoms on at least one encounter: URTI, pain, fever, flu, jaundice. In the 2024 calendar year, we had 348 total patient encounters. About 1 in 5 was to treat symptoms, and about 4 in 5 are routine visits to refill their hydroxyurea. The top 3 causes of significant morbidity are upper respiratory tract infection, pain, and fever. So with that background, I'm going to hand over to Musao Joel to present the case. He's going to, and I'll just show you quickly so you know, he's got description, we've got test results, we've got examination, and then we want to show you the ultrasound equipment that we have, get your advice about that, and then the ultrasound report with 3 images. So Musao Joel Kibonyo-Obake, the director of the Sickle Cell Clinic, go ahead and present the case.
Thank you very much, Professor Stewart. I'll present part of the case, and the Chakwa Ben and Brian will present part of the case. I'm Joel. On 15th July 2025, we received a 5-year-old male who is having blood group O positive in our outpatient clinic. By the time on his visit, he was having a distended abdomen that had lasted for 2 months, yellowing over the eyes that had persistently stayed for 3 months. He was sick looking and he was irritable. Medically, this is a known sickle cell patient who was diagnosed in the first year of life and has recurrently been followed up due to his poor health experience, and actually that was multiple blood transfusion. So in the treatment history, this young man has had series of treatment both in different places with traditional herbal and Western medicine, and had multiple transfusions. He is currently on hydroxyurea of 20 milligrams per kilogram body weight. It takes 500 milligrams once a day for 5 days. Next. In investigatory history, currently we have been taking a study for gazelle monitoring, and this is one of our clients. We have 3 samples in 28th of August 24. He had a sickle cell was at S was at 61, F was at 30. Then 24 September 24, the S was at 62 and F was at 38. That's a reduction. In on 26 November 24, S was at 66 and the F was at 34. Then on 14th May, S was at 67 and F was at 33. On examination, on that day when he came, we realized that anemia, it was plus, jaundice was plus, edema was plus. He was not having dehydration. Then we had to plan the investigations, and the investigations were Mr. Chakwa Ben and Brian. I would like Chakwa Ben and Brian to take over from here. Are you around?
There we go. And Chakua is a clinician at the clinic also. Go ahead, Chakua.
We start from the investigations.
All right. Good morning and good evening at once. Good morning to those in USA. On the investigation, we did a CBC First, we started with the hemochu. Our CBC was down, and it was showing 4.5 grams per deciliter, and we are seeing the hemotoxicity. And I will use also a guideline from Lago National Regional Referral and from 2020 Sickle Cell Guideline, where we define hemotoxicity using the following. So when the HB is below the level of 5 milligrams per deciliter, or if the HB is below 6 milligram per deciliter and the reticulocyte count is less than 100 exponent 12 per mil, then the average neutrocyte count, when it is less than 1.5 exponent 9 per mil, and platelets count less than 80 exponent 9 per mil. So when you look at the HB was down, when you look at the neutrocyte count average, average was in a normal. Actually, these are microliters, was in normal range. But when you look at the platelets, they are way far below 80. They are on 51. Then when we go to reticulocyte count, okay, maybe forget that the reticulocyte count was also low. So, basing on the criteria that we are using on the 2020 Uganda guideline and the Mlago guideline, the pediatric child was following under the hematological toxicity basing on those ones. But as well, the gazelle, it was showing that the hydroxyurea, which increases production of fetal hemoglobin, was doing its work. Yes, but again, maybe it was doing another harm. So we decided to stop hydroxyurea as we monitor for 3 weeks. On abdominal exam, there was increase. There was hepatomegaly and mild hepatomegaly and moderate splenomegaly. Oh, I've jumped. Okay. And yes, so we admitted the child, and we gave PACT cells 200 mils. Now, here this side we usually give 10 to 15 milligrams per kilogram of PACT cells. We encourage the mother to continue with Fancida, which is, remember, the baby had also the baby had also reported back for drug refill. And then we continue with the PNV for pneumococcal prophylaxis and multivitamin. And we suspended hydroxyurea due to those cell complete blood counter parameters. Now, the challenge we faced, we couldn't do a renal function test to actually trace ALT and creatinine levels. We couldn't do to see alanine transferase levels less. Are they less times to the upper limit, or do you have normal creatinine levels? And we couldn't also look at the bilirubin levels. And remember, he had severe jaundice, and this one also affected us on our research. Yes, ultrasound scan. Okay. So the indications are presented, and I think this one, Mr. Joel, can you present, maybe I'll come in later, the ultrasound scan
Yes.
findings.
Yes. Thank you. Thank you, Chakua. We can do, let me look one back, Professor Stewart. Okay. At the beginning. Well, we did abdominal ultrasound scan. This is a pediatric ultrasound scanning indication because you had jaundice and the abdominal distension. So in the preparation of our case, the procedure was explained to the mother. We put the mother in the recumbent position. We draped. Privacy was observed. We used a butterfly. At that time, we used a butterfly, and we used a preset of the preset with a normal frequency and path and gain. So the findings: the spleen was grossly enlarged in size at 12.3 centimeters, with a significantly increased echogenicity and a normal echo texture. The liver was slightly enlarged in size, measuring 10.4. We are talking this in terms of a pediatric of 5 years. So that is 10.4 centimeters in mid-clavicular line with a normal echogenicity and echo texture. The gallbladder was not well distended at that time, with a wall measurement of 0.9 and a posterior acoustic enhancement. So no more results.
So Musao, Joel, we have 3 more minutes, so why don't we run to the conclusion and show the images?
In our conclusion, we were having gross splenomegaly, we had hepatomegaly, and the gallbladder was thickening. Go to the image, Prof. So image number 1 is showing the gallbladder, which was not well distended with posterior enhancement. And when you look at the wall, it's somehow thick. We can go to number 2. This is the spleen, which was enlarged. And the normal is supposed to be 8 at that age. Then you can go down to number 3. Number 3, we had the liver, which it had the texture almost looked normal, but it had also enlarged. Thank you very much for that. Do we have another number 9? What's the number 9? Okay, that's fine. So you can show us the picture of the back on the machines we are using. So this one, let's start. That one is what we used. It is this one is the butterfly that we have been using, and we use it on the iPad. Supposed to use iPads or iPhones. You can go to another machine, doctor. So this one is called a Chisholm. It is having both a linear and a curvilinear, and it's outside of the facility. The other one is mobile. This one is fixed. I think with that, with that and time, I want to thank you so much. And there is a disclaimer down at the end of the presentation. Thank you for listening.
Thank you. And we're also looking for support from the group because we've lost our license for this software to use our butterfly. We have a graduate student who's traveling in September. So if anyone knows of any way that we can update our equipment, we'd be grateful. So that's our case presentation. We go back to the first group.
So I think we ended on this repetitive video of the right upper quadrant. And so we'll talk a little bit about the left upper quadrant. So similar, except when you're scanning the left upper quadrant, typically it's more posterior than the right upper quadrant. And so I'm right-handed, so I usually stand on the patient's right side. So I have to reach all the way over the patient. And I usually have to end up with my hand or my knuckles on the bed. So these structures are a bit harder to find. The kidney is more posterior. And so that is the challenge of the left upper quadrant. But here we're assessing for free fluid between the spleen and the kidney or above the diaphragm as well. Suprapubic, so we typically will obtain 2 images of the suprapubic window looking at the bladder, just because it's the most common area for free fluid in children. So one of them is a transverse view. Probe marker is again toward your left or your patient's right, and fanning kind of from head to toe to evaluate whether there's any free fluid, typically in the area below the bladder. And then another view where the probe marker is toward the patient's head, a longitudinal view, where you're sweeping from right to left, the patient's right to left, and assessing for free fluid as well. The cardiac window in the FAST is a subxiphoid view. So underneath the patient's xiphoid process on their chest, in that little depression, your probe goes there. You're scanning through the liver, using the liver to take images or to pass the ultrasound through to take images of the heart. A little bit of gentle downward pressure. If your patient is a child, they may not appreciate this very much, and so might cry. Having them bend their knees sometimes helps. And this will give you a view of the heart, the right ventricle, left ventricle, and you can just assess whether the squeeze looks adequate, whether it looks robust to you, or whether it looks like it's has any fluid around it. And then the last part of the EFAST is the lungs. So assessing for pneumothorax or pleural effusion, and we'll show some images of those. So when you are scanning the lungs, typically we'll use the linear probe. So I do change probes during my EFAST exam if I have time. And when you're scanning the lungs, what you're seeing is that bright white light line at the top is the visceral and the parietal pleura rubbing together. That should be moving. We say it looks like ants marching or stars twinkling, and it will be flanked on 2 sides by your ribs, and those shadows are because the ultrasound beam can't go through the bone, so you see that as a shadow. So these are just some quick examples of pathologies you may see when you're doing an EFAST exam. So this is a right upper quadrant view where we have the liver and the kidney, and you notice underneath there's this bright white structure. That's the patient's spine. So we shouldn't typically see that above the diaphragm area because air doesn't conduct ultrasound waves. But when there's fluid in the lung replacing the air, then the ultrasound waves can travel through and we see that spine extending all the way out. So that's an indication there's free fluid, or so either fluid or blood in your patient's chest. These are a couple other examples. This is another right upper quadrant view. It looks a little dark on my screen, so I apologize. But again, the liver and the kidney and free fluid is dark black in color, and we can see that kind of right above the kidney. This is a subxiphoid view, and again, it's a bit dark, but you can see the heart is here, and there's black surrounding the heart. So this has both pericardial effusion around the heart, but it also has a lot of fluid out in the sort of exterior region here, which is pleural fluid. And the reason I can tell that is because I look at this circular structure right in the center next to the heart is the aorta. And so any fluid that is going to be pericardial around the heart comes between the heart and that aorta, and any fluid that is outside of that aorta would be pleural in nature. So this patient has both pleural and pericardial effusions. And there's the aorta that I was talking about. And then these last 2 are some suprapubic images. The image on the left, you can see the bladder, and there is some black fluid outside the bladder. There's also a large structure inside of the bladder. This patient was having gross hematuria, so that is a blood clot. And then this image on the right is another suprapubic view, and this black that you see right below the bladder is free fluid. And then last but not least, this is an image of a patient with a pneumothorax. So if I look at the left side of the screen, if I'm looking at that bright white line that is next to the rib, the pleural line, I don't see a lot of movement of that. Sometimes it can be hard because there is some movement. Obviously, when the patient, their heart beats or whatnot, there is some movement in the chest. But I can use my M mode, which measures the motion over time, and it should show that there is not motion of that pleural line. We call it a barcode sign. And we can talk more about that in a bit. And then last thing, a couple of pitfalls that we see commonly for the FAST exam. One of them is folks who are visualizing the stomach in the left upper quadrant. So if you think about it, your stomach is one of the more anterior organs that you have. And so when you're imaging the left upper quadrant, if you are not in that posterior axillary line, you may pick up the stomach with its contents, swirling inside that looks like fluid. The way to adjust for that is to kind of shine your flashlight more toward the posterior part of the body, more toward the spine, and then that should allow you to see the spleen and the kidney better. Another area that we see confusion is in the suprapubic region, people may mistake bowel for free fluid. So in this example, the first structure that you see is the bladder, and then as you're fanning through, you see the structure to the left that's kind of swirling. There is black in it, but it's not free fluid because it's peristalsing and moving. And so we know that's bowel. Sometimes you just have to pause there and look for a moment to decide whether it's fluid, that fluid is within your bowel or is external. Two other pitfalls. So when you are doing it fast and you're looking at the right upper quadrant, just be mindful that there are blood vessels in there. So your hepatic vessels and your IVC. And so those sometimes can be mistaken for free fluid. You can put color on those. Knowing that they're there also helps you to avoid calling them free fluid. And then the last one, I think, is just a general statement. If you aren't able to get a full view of the area of interest, then you may be missing things. So just being cognizant that if you're not really seeing the hepatorenal space, or you're not seeing the bottom of the kidney or the tip of the liver, you may be missing something. So just notice that. And I'm going to turn it over to Erica to talk about bowel, and I will not click on that Vimeo clip.
Thanks, Beth.
Yeah.
And just one other comment about fast pitfalls. If you see something that looks unusual and you're not quite sure what it is, looking in another plane, so turning your probe 90 degrees and getting an axial view through the abdomen can sometimes be helpful, especially with that stomach view, because that would show you the stomach next to the spleen so that you could tell they were two different structures. So when we talk about scanning the bowel, in adults, a lot of times we're looking for small bowel obstructions. That's one area where we overlap with pediatrics. Beth is going to talk about, Dr. D'Amico is going to talk about intussusception as well. Both of those you would use a pretty similar technique. And the goal is that the bowel obviously is dispersed throughout the entire abdomen. So you want to try to hit all of the areas. There's not one focused spot that we're going to look at like we do with a FAST, because we can't predict where the pathology will be per se. So this picture is somebody kindly let them draw the path that the ultrasound probe should take on his abdomen. But basically you're going to sweep up and down and try to cover all of the territory in a very methodical way so that you don't miss an area of concern. You can also sweep across left to right or right to left. As long as you're covering the whole territory, you should be able to see what you need to. You can also start this process from wherever the patient is the most tender. So if it's an older child who can sort of indicate an area of most tenderness, that can sometimes be helpful as well. So in talking about small bowel obstruction, the pathology you're going to see is dilation of the loops of bowel. For pediatrics, the actual diameter has not been fully determined, or the cutoff, I should say. In adults, we talk about a diameter greater than 2.5 centimeters, but there have been at least some case reports in children of 2 to 2.5. And so recognize there might be a little bit lower sensitivity if you use that higher cutoff. You may be missing some cases if you look at 2.5. But these are some examples of another finding, which is, in this case, to and fro or bidirectional peristalsis. So instead of peristalsis moving forward as it should, if you watch the intestinal contents here, you can see them kind of moving back and forth. That's obviously because there is an obstruction distal to this area that's not allowing those contents to move forward. On this side, this is a slightly more concerning finding of absent peristalsis altogether. So at this point, potentially this is a longer standing bowel obstruction, and there may even be some degree of bowel ischemia because you're no longer seeing any movement. You can also see one subtle finding, which is a little triangle of free fluid here that can sometimes happen again as the bowel becomes threatened and the wall becomes leakier or even necrotic. So watch out for that. This is an example of a larger amount of fluid, so this would be an even more concerning finding. If your patient is suspected of a bowel obstruction, this could signal, again, ischemia or necrosis. You can also see the difference between the liquid, solid, and air contents in the bowel. You can see the different air artifact that you get, which I think a lot of people who've scanned the abdomen are very familiar with. It gets in our way when we're trying to look behind it. But this helps us to outline the loop of the bowel because of this fluid here and see all those different elements within it. This is actually an incarcerated hernia, but I wanted to show you the findings of small amounts of air within the wall of the bowel, which is pneumatosis intestinalis, which again, you can see in threatened or ischemic bowel from any pathology, including incarcerated hernia or a high-grade SBO.
So that's the white, bright white in the wall.
Yeah, these
Okay.
small little white dots, and I think a little bit. And there are a couple of small bubbles here that you can see actually going through the different mucosal layers as well. So these are very atypical findings. You shouldn't see air within the wall itself. And that's why I showed this is air that's inside the lumen, and it can be kind of subtle. This one is obviously zoomed in a lot more. This is where they're using, we talked about the probes before, a linear probe versus this is a curvilinear probe that shows deep structures, but not the shallow ones. So if you wanted to get a better look at the surface, you can switch to a linear, and then that would show you that that air is actually within the wall of the bowel and not underneath it inside the lumen where we would expect it to be. I think, and I'll turn it back over.
Sure. So one of the things you may also see when you're scanning the bowel is specifically looking for an intussusception. So that can occur in a couple of different flavors. The one that concerns us most is an ileocolic intussusception, so small bowel to large bowel, because that will not self-reduce. That needs assistance to be reduced, whether that's an air enema, a contrast enema, a surgical procedure. And so it's the same technique. We call it kind of a lawnmower scan. And when you are typically in some region on the right side, so either the right lower or the right upper quadrant, you are looking for something that we call a target sign or a bullseye sign. So you can see that coming out in the center of the screen here, as well as the image on the right. You can see that, and that is basically a cross-section of the bowel that has telescoped into the larger piece of bowel. And yeah, if you have any difficulty deciding whether or not you're seeing an intussusception, like Erica was saying, it helps to rotate 90 degrees and try to see it in a longitudinal axis. And so this is a person attempting to do that, and you can kind of see the target sign in the beginning, and then you can almost see the loop of one loop of bowel within the other loop of bowel. There should be color flow. We should have good blood flow still to your bowel that is intussuscepting. So if you're not seeing that, that's concerning. Just as a reminder, typically we would see intussusception in children around 6 months to 36 months, so 6 months to 3 years old. I have seen it in young children as young as 2 months old, and I have seen it as old as children as old as 9 years old, but the 6 to 36 months is typically what we see. And they often will have nonspecific vomiting and diarrhea. Sometimes they'll have lethargy. Sometimes they'll have bloody stools, but not always. And so this bowel scan can help you identify that. We have a few cases. We'll just maybe run through one or two of them. So this is a patient, a 13-year-old boy. He was riding his bicycle and fell and hit his left side on the side of the street. He came to the hospital after he walked his bike home and finished whatever he was supposed to be doing at home. He, on his physical exam, had abrasions and bruising to his flank and upper back, as well as pain in all of his abdominal quadrants. His vital signs were notable for tachycardia, and mild tachypnea with oxygen saturation of 93%. The team evaluated him with a fast exam. This is his right upper quadrant view, and I don't know if anyone wants to take a stab at interpreting the right upper quadrant, whether there's free fluid present or not. What do you think, Erica? I'm gonna call on you.
Oh, I think it's positive.
Yeah. At the lower pole of the kidney, the top, there's a small black stripe. I'm not sure how well the images are showing up for you, but there is at the tip of the liver some free fluid there. So the right upper quadrant is positive. When I look, this is the left upper quadrant view. And so I'm looking at the border between the kidney and the spleen. And while I don't see anything there, I'm not able to see the very tip of the inferior pole of the kidney that well. So that's a limitation of my images here. I also note when I'm looking at the spleen that it kind of has sort of, it's not as smooth and homogeneous as I typically am used to seeing. And that's just sort of pattern recognition. So that would concern me given the findings on the patient's left side.
And keep in mind that's different from that image she showed earlier where the stomach is
yeah.
in that space.
Yeah, I can see that it's still splenic tissue, but and then this was the patient's suprapubic region, which you're able to see there's quite a large amount of black fluid tracking along underneath the bladder. So this was quite positive in this area. And his subxiphoid region, we were able to see that he had good cardiac function. I didn't see a large effusion. And finally, we looked at his left lung because he was having some shortness of breath. And so in the beginning of the clip, you can see, I think, pretty nicely the shimmering at the pleural line or the ants marching. And then as we move down the chest, there's a rib space. There's the next pleural space. It doesn't seem to be moving. So we were concerned for this patient having a pneumothorax as well. So this patient was found to have a splenic injury as well as a pneumothorax. Fortunately, he was able to be managed non-operatively and recovered well. This case, I'm going to skip through because I think it is not as helpful. And then maybe we'll do one more case. This was a patient, a 5-year-old patient. This was a patient actually I cared for in Malawi. He presented with fever and abdominal pain, had fever for about 10 days, also had some diarrhea at the beginning of his illness, but since the past 5 days, he has not had any stool output. His belly was distended and he was having difficulty breathing, was quite febrile, as well as tachypnic and some lower oxygen saturations. So the team caring for him did some ultrasound exams, including a bowel exam. So this was his right lower quadrant. As you can see, his bladder coming in at the side here. This was the right upper quadrant. And you can see a little bit of peristalsis in that view, but not too much. This was his left lower abdomen, and it would have been lovely if we had made it a little bit brighter, but again, there was not too much peristalsis in that area. And similarly, we are seeing that again. So the team was concerned because there was not a lot of movement seen in this patient's bowel, given his history. And this might be an example of just like the start of that back and forth or to and fro movement of the contents of the bowel, kind of consistent with an obstruction. So this patient, we're quite concerned that he had an obstruction, I think potentially from typhoid. And while we were scanning, we completed the fast exam on this patient and also noted that his cardiac function was somewhat depressed. So we got additional information, probably not necessarily related to his obstruction, but helpful to know about this patient.